Please, Dr. Ahmed and Dr. Snyder, the stage is for you.
Hello, thank you all for having us be here. This is really a wonderful meeting, and it's a pleasure to be here. The Mike and Ike Show is a really very dear thing to me. We're going to turn things upside down and really make this a lot of fun, though. I think hope you guys really enjoy it. It's extraordinary, and we're going to present. This is actually the 8th time that Ike and I have been doing this extraordinary thing, and we're going to show you some extraordinary cases. I'm Mike. That's Ike. And now, this is actually the 8th time that we've been doing this. As it turns out, it would have been the 9th, except back in January when we were going to be doing this is what Ike looked like. He wasn't feeling well, and so we didn't get to do it back then. So this is actually our 8th opportunity, and we are on a mission to show you some really amazing cases. So I just want to throw out some regulatory stuff, which probably isn't that important here, but back in the U.S., we have lots of limitations. We're actually not even allowed to use implant lenses in children, but we do anyway. We're not supposed to be putting implant lenses in the sulcus, but we do anyway, and sutured lenses as well. In the U.S., Gore-Tex sutures, which you may see here, are off-label, and Trypan Blue for some of the reasons that we use it off-label. And I just want to show my disclosures because I think this is the first time I've been up here. These are the companies that I'm working with and the ways in which I am working with them. I just want to quote Ike here for a moment back from 2011. He commented that even the most complex of cases can be broken down into discrete challenges with discrete steps to conquering them. We've selected some cases to entertain you and use a couple of principles that may apply to many routine cases as well. And each case may have many messages. And whether you choose to do cases with multiple challenges or not in the same eye, it's good to have these weapons in your arsenal so that you can use them should the opportunity arise. And you may not always be aware of the challenges before you start the case. So this is a great opportunity to tuck them away just in case. And there's often more than one right answer. So Ike and I sometimes will disagree about things. Now this is a patient who was referred to me, and this is exactly what they look like when they were referred to me. So the referring doc calls me up and he says, well, so I'm in the operating room and I did a capsulorhexis and I started phacoing the lens and it was just too dense. So I just put a patch on and I sent the patient over to your office. So here we go. So as we start the video here, I have no idea where the capsule is, so I'm going to start off before putting viscoelastic in and put in some aqueous. The incision's going right across the wound, so I do need to reopen that and reopen those sutures. And we allowed a good bit of stain, which then I'm exchanging for a dispersive viscoelastic. And you can see that it actually highlights the capsulorhexis very nicely, and also highlights the edges of the lens. Isn't that neat? The wound was actually quite anterior, you can see, and in a dense lens like this, the anterior wound can cause dimpling and make it a lot more difficult. So we created a posterior wound further back into the limbus so that we'd have a little bit better view. And I showed a little bit of this just showing that this is a very dense lens. You could actually hear me groaning as I was trying to break the lens into pieces, and you can see that even though we're going as deep as we can, there's still that leathery plate that Ike often talks about trying to move things along. Fortunately, we've got a relatively mobile segment. I'm a big fan of using a horizontal chopping procedure in these very dense lenses so that we don't put excess stress on what usually are fairly weak zonules. I also want, you can see that our break is going right down deep in there. I also want to call your attention to this thing over here. That's subconjunctival triamcinolone, or Kenalog, which the previous doc put in, and you can see the needle hole through which it went in. Oftentimes those needle holes will not close. So with these dense lenses, I'm a big fan of adding dispersive OVD numerous times throughout the case to make sure that as the OVD is depleted, we're still protecting our endothelium. So my record is 7 tubes of dispersive OVD in one case. That case took a while. And we can see a couple of bubbles, but those bubbles came from the infusion tubing. If we start to see small bubbles, that's when we start to worry about whether we have an occlusion and whether we're going to be building up heat energy during the case. And that's something to avoid. So we're going to work along a little bit quicker through, always using our second instrument. And you can see the pupil's getting nice and big now, right? So adding more OVD and more OVD. And we repeat the process over and over and over again. And after a while, I'm looking at this and saying, well, this is a pretty dense lens, and this is a pretty small pupil. So I'm really worried that I might get a post-occlusion surge. So I'm going to put in a posterior capsule protector. As it turns out, this posterior capsule protector has dioptric power in it, too. It's very convenient. And we're just placing this 3-piece lens into the anterior chamber so that we can get the remaining fragments. The most likely time to get a post-occlusion surge and break a capsule in a dense lens is when there's only a couple fragments left. So with this in place, our chance of damaging the capsule is near nil. We can then finish the phacoemulsification without worrying about our post-occlusion surge. And then we simply take the implant lens and dial it into its proper position. We remove the OVD from behind the implant, as I always do. Inject a little myostat at the end of the case so for IOP control in these very compromised eyes, and end up with a very happy result. So the couple things that I like to think about with cases like this is that when there is a capsule that's already been violated, you want to jump in pretty quickly. So I wouldn't leave it more than a day or two at the outside. Wound security is really important. Trypan Blue, wonderful tool. Repeated viscoelastic installation, and making sure to modulate our power and watch to make sure that we don't get too much heat so that there's constantly flow coming through the needle of the phaco handpiece. And using the IOL as a scaffold for protection of the capsule and for mydriasis. And over to Ike. Can we switch the presentation to the other podium?
Thanks, Mike. It's kind of interesting, actually. I was going to just, I won't show the whole case there, but if we can go to this laptop over here, great, thank you. These are my disclosures, by the way, and it's interesting, I think we should probably make a series of these. This actually was referred to me as well, an aborted phaco. And I won't go through the whole case, maybe if we have time later on, but maybe we could put together a series of aborted phaco rescues. I think they're pretty cool. Well, it really is an honor to be here with Mike, because Mike is, as you know, of course, is an amazing surgeon and a person and an innovator, someone I've learned from, over the years. And he also, I think, makes a good job as a model, no? I mean, but he should be more, not lens star, should be Botox model, I think, Mike is beautiful. Okay, let's talk about this case here. This is a young 4-year-old patient, and everyone knows the diagnosis here, posterior polar. Obviously, we need to think about the challenges, of course. These patients often have capsules that are very thin or sometimes deficient. You can see this patient done under general anesthesia. And we have to think about not only getting the cataract out safely, but also how do we prevent posterior optic axis opacification, visual axis opacification, or PCO. I do like to use Trypan Blue here because I think it does reduce the elasticity of the capsule, and these young pediatric eyes and babies, for example, I think it adds an extra level of control. We know, of course, the rhexis is important in these cases because sometimes we need to use the capsulotomy as an alternative support as necessary, and the use of a super viscous agent like Helon 5 again really flattens the capsule. So I don't use Helon 5 routinely, but in these complex situations here, I think it's great to get the capsule flattened. This and intumescent lenses, very handy to use Helon 5. And then, making this rhexis starting off a little bit small, you can see it wants to stretch out, and being prepared to continue with shearing, but also necessary, convert to a stretching technique if the rhexis is running out. You see at the very end, we'll kind of just, stretch more as opposed to shear to get hopefully a reasonable rhexis. And as you can see, this can be done reasonably well without femto. Now, the key point for me, certainly, in our experience over the years, is to avoid doing hydrodissection. A hydro wave may potentially blow out the posterior capsule. And so all I'm doing here is just simply manually roughing up and loosening up the cortex. And then these are soft lenses, of course. So hydrodelineation, as you see here with the chain cannula, very handy to separate the epinucleus from the endonucleus. And these are soft, so we remove the central endonucleus first and try to trim the peripheral epinucleus prior to removing the central plaque. This at least protects us a little bit without exposing us to the potential risk of the posterior capsule. Here you can see the capsule is actually intact. Most of these capsules are intact in our experience. unless the patient has a lenticonus or a breach present. And before coming out, we'll inject viscoelastic. Now the attention is spent, how do we manage the posterior capsule here? This patient, again, remember, is a young patient, and for all my young patients, patients who are typically under 6 years old, we typically do a posterior capsulorhexis. And this is using a 27 gauge bevel down, injecting dispersive viscoelastic into burger space. These patients have fairly formed vitreous, and so I think just keeping the chamber formed and preventing collapse is important. And then we'll use a pair of microforceps to start and continue the posterior capsulorhexis. We train our fellows routinely on posterior rhexis. I think it's something that is not as difficult as we think it is. As I said earlier today, we have microinstrumentation. It's important to understand the capsule's thinner, but there's less tension drawing the capsule outwards. The zonular tension is less on the posterior capsule than the anterior capsule, and of course we're working more in a concave environment rather than the lens being convex into the anterior chamber. But it is harder to control, of course, because the capsule is thinner, and we're working on a steeper inclination. And more viscoelastic here to do this. And so again, using both the shearing techniques as well as stretching techniques to ensure we have a good rhexis. I find this to be something that is reasonably well. Start small and enlarge it. This patient also has a fair amount of astigmatism in this case as well. Often, as you see here with the rule, I think this was about a ZCT 400 lens at the time. And so basically we put the lens into the capsular bag, but now we're going to prolapse the optic behind the posterior capsule. And this really is a great way to prevent secondary visual axis opacification. You can see I'm just showing the marks on the cornea. I don't typically use ink. I just use a little epithelial marker to mark the cornea. And then we can prolapse the optic through. So the haptics are sitting in the capsular bag with the optic behind, the so-called posterior optic buttonhole technique. Number one, of course, this toric is not going to rotate, but more importantly, there's nowhere for the lens epithelial cells from the equator to migrate over the capsule or the hyaloid. And then we remove the viscoelastic manually, always suturing these wounds, because at the end of the case, the risk is the chamber can shallow, and so we want to do this under control. I don't like to use the IA here. I like to remove it manually because this prevents the chamber from shallowing. So that's a case of a posterior polar in a very young patient with the principles in managing pediatric cataracts. Over to you, Michael.
Ike, that was a beautiful case. The other nice thing about the posterior optic capture in this instance is that it's going to lock the toric implant lens in place too, so there's no way that you'll ever get rotations. That's beautiful. Can we switch to the other set of slides on the podium? So this next case that I'm going to present to you, can we switch the podium, please? That's actually what the case might have looked like had we been less attentive.
That's just an intermission picture. Brain, testes, and feet. Your favorite meal, Michael. I know you love this stuff.
Is this from Canada?
No, it's from the Middle East. Can we go over to Dr. Snyder's laptop?
So can we please change in the back? Can we change the video? So I'm going to tell you about the case, and then we'll let you see it. It's a 54-year-old gentleman who Ike had fixed his other eye, but then he moved down to Cincinnati. And he was struck in the left eye with a staple and some wood. That's all he really knew. He had an abrupt loss of vision since a ruptured globe repair, which was done 2 days previously. And his vision was light perception, tension was 8 millimeters of mercury, and there's clearly a damaged nasal iris, posterior synechia, and a white lens. So there's a couple things going on here. First, let's show his topography. He's got some fairly regular astigmatism. And here's what his calculations look like. There's really nothing overly dramatic. Cell counts don't look too bad. So, what would you do with this case? We've got some problems. Well, we've got some normal astigmatism, but we've got an opening in the cornea, opening in the iris, probably an opening in the lens. Decent cell counts and decent targets here for the implant lens. Yeah, just as we talk about some things implant lens-wise, Ike, do you want to just throw in 2 cents? Would you put any restrictions on implant lens options in a patient like this?
Sorry, there's a wicked echo on that. Sorry, what was that you saying?
Would you put any restrictions on an implant lens option in a patient like this?
No, if I feel the capsular bag, I can get a lens in the capsular bag. Those honors are okay. I'm okay to put a toric in here.
Awesome. Yeah, I felt the same way. I always like to mark my axis at the beginning of the case. We use pictures that are taken through the lens star at the very beginning of the case. The picture is taken at the same moment through the machine that the keratometry is done, so it's relevant to the globe. And we've pressurized the anterior chamber. Usually I put trypan blue in first, but here we know that we've got a bunch of pressure in the bag. So we've pressurized the anterior chamber with OVD. We're purposely not opening up the synechia to the capsule just yet. We've stained the capsule. And now this is a 25 gauge needle piercing the bag on a 3 cc syringe, half filled with BSS, and we're aspirating the liquid cortex to remove the endolenticular elevated pressure. Now we can do this capsulorhexis as a more routine case. I suspect that there's an opening in the anterior capsule underlying that iris, and I don't want to break that any further. And I might need to use the anterior capsule to fixate my implant lens, so I'm being very attentive to make the opening of an appropriate size for removal and being able to capture a 6 millimeter optic. This is a relatively young patient and a relatively fluffy cortex, so we remove some of the cortex initially just with manual aspiration. And you can see we now switched over to the phaco, and it's a little bit on the sticky side, but we're able to bring some fragments in. I don't like to do a hydrodissection when there may be an opening in the existing posterior capsule. Just like Ike mentioned in the case with the posterior polar, I prefer in these cases to just chip off and bring forward one little piece at a time. And rather than moving the lens, I like to just move my instrumentation, since if there is a penetration of the posterior capsule, rotation is highly likely to break that open even more. So we just go through a little bit, piece by piece, and we pick away each little piece, nuclear material out. We repressurize the anterior chamber just as you saw Ike do with the posterior polar case, and the cortical removal becomes much more straightforward. As it turns out, there wasn't an opening in the posterior capsule, so I figured, well, why not just create one? There was some plaque, and I was all excited that there might be one there, so I might as well leave the case with one. So we just did a primary posterior capsulorhexis for the plaque. And as you've seen before, sometimes it can get a little bit harder to do if the capsule is very thin, and so switching to a vitreoretinal max grip forceps might give a little bit of extra traction since the posterior capsule is fairly thin. And then we just peel that around. So if you don't have a vitreoretinal forceps in your room, there's really great microinstrumentation from MST, but not everybody uses the anterior segment ones. You can always go into the room next door and get the vitreoretinal equipment when they're not looking. You can distract them, right? And then just placing the implant lens into the capsular bag. And in this instance, it turns out that the pupil is going to be a little bit eccentric, so we wanted to close that one gap. Put a couple little sutures in there to get a more central pupil. Now this technique is really important. We're going to use, after we tie the suture, we've got a slightly abnormal shape to the pupil. So this is a technique that Ike taught me, where we use a micro-tip cautery, and we just go a little bit outside the sphincter and apply a couple little small spots, and then we can sculpt the shape of the pupil really beautifully. The control of this is really very seductive, and you can get it quite round. I probably could have stopped a few minutes ago, but it was just really so very satisfying. So the final tips in the staple that case, he ended up 20/20, which was great, but it's really important that if you've got synechia that are stenting and opening in the capsule, not to try and break those synechia. Use that scar tissue in stenting. Always think about the astigmatism irrespective, trypan blue for visualization, over-pressurizing the anterior chamber, and aspirating the soft cortical material before the capsulorhexis using a 25 gauge needle on a 3 cc syringe, half filled with BSS. Iris sutures and iris cautery are just a wonderful way to work with things. And back over to Ike. Can we switch the presentation to the other podium?
Perfect, thank you. Okay, we got the switch down. Yeah, I love the cautery. Kind of it's like a little eraser, you know. You can kind of just change the shape as much as you need to. It's amazing. Okay, so this is something that we often do see, not this, sorry. So yeah, this is basically brain, testes, balls, whatever you call it in Dominican, and feet. I know Mike is very adventurous with food, so he loves trying new things. So bring him new things tonight for dinner. Okay, this is basically a trauma case with a capsule plaque. And, you know, we know that these plaques can be difficult, particularly because these are typically subcapsular plaques. And the use of trypan blue is nice because it actually shows you these fixed folds that are present on the anterior capsule. In my experience, at least, I think it's very difficult to get a smooth capsular exit. And this may be, Mike, I don't know, this may be one situation, maybe, where maybe femto might have an advantage, possibly. What do you think?
Nah.
No? Even then? Okay, even then. There you go. Michael's rendered his opinion. We start the rexus in an area beyond the folds, see if we can get at least a continuous tear started there. And as expected, as we get toward the folds in the capsule, we find that we get stuck basically. We cannot continue without pulling the zonules in the capsular bag. And again, there's a fair amount of fibrosis here. You can see we kind of get halfway through it, and it's fairly tight. What do we do in this situation here? Well, we continue to fight a little bit here, but eventually we're going to say, you know what? Despite all the pulling and the prodding, you can see that there's still a fair amount of fibrosis there. We're going to start and make a little cut, a little nick with a pair of micro scissors, and carry on the dissection, capsular exit in the clockwise fashion. And not surprisingly, of course, once we get to that capsular plaque, once we get to the area of the capsular folds, we have trouble again. We can't continue it. And if we continue to pull, a couple things will happen. One, we may disinsert zonules, or two, we may cause an irregular tear out in the periphery. So at this point in time, we'll grab, this is nice to have a bimanual approach here, a pair of microforceps to hold the capsule, apply tension, and then cut along the axis of where we intend to. And then we can carry on with the case. It's a fairly large plaque. I'm going to say I'm trying to visco-dissect the plaque off of the capsule. I do it with some partial success there. You know, you can often actually dissect that capsule from the plaque very carefully in some cases. I'm able to cut the plaque partially here. So now I'm cutting the plaque, not the capsule itself. And then we continue on with phaco. Again, it's not a very dense cataract. Remove the cortex. And very important prior to coming out. Sorry, I'm still obsessing about that plaque. Sorry. Like Michael, I'm a bit obsessive with some of these things, and I'm seeing if I can nudge it away. Is it break? There we go. Now I got it. And you can see, of course, that the capsulotomy is irregular, so it's important to prevent the chamber from shallowing to avoid the tear from running out. And once we do this, we have an IOL in the bag. And this is, again, a way to manage some of these cases with capsular plaques. So be prepared with the right scissors in our hands and microforceps as needed. Okay, over to Mike.
Okay, can we switch the presentations again? So, Ike, you were actually prescient because this case is going to require a little bit of brains, probably need a little bit of balls to do this case, and you probably want the feet to run away from it if you're smart enough. So this is a case of a patient who had previous radial keratotomy, and the patient fell and lost the iris and some of the vitreous through one of the radial keratotomy wounds. A vitrectomy was done by the vitreoretinal team. Cataract became quite significant, and now we've got a super dense lens with a 6-hour zonular dialysis. So in this case, we can't start off with trypan blue alone. We've actually put some OVD in first, otherwise the blue dye would get into the Are we good? Okay. So otherwise the dye would get into the posterior segment. So we put a viscoelastic plug in first, and we're going to do a capsulorhexis just centered on the geometric center of the lens. And you can see here I'm using primarily my instrumentation and dispersive OVD to stent the edge of the capsule. We could put in capsule hooks in this instance, and that's certainly a fair thing to do. Sometimes they work very, very nicely, but sometimes less is more. And if we're able to maintain a reasonable shape of the capsular bag by viscoelastic material, it also makes sure that we're protecting our endothelium adequately. And this is a relatively straightforward approach. And now we're just expanding, getting out a little bit of the cortical material with Bob Osher's dry aspiration technique. As long as the anterior chamber pressure is high, I have no concerns We're reinflating the capsular bag, and I'm feeling really quite happy about things. And I'm happily going along and feeling quite proud. And then we start to notice something. That doesn't look right. That really doesn't look right. That looks actually pretty bad. So we're seeing something going on. Hey, Ike, you want to guess what's going on there? I'll make a tough question. What do you think's going on?
Not good. Not good.
So, not good. So this is an acute suprachoroidal hemorrhage. So we've basically now tried to stabilize things. We've put a bunch of OVD in. We've got an anterior infusion. And now I'm going to actually show you this part of the case. I called Chris Riemann from across the hall. And I said, hey, Chris, you doing anything? And he came on by. And you can see, look how deep he is with that blade there. So, Chris probably used some of the material from those trays you showed us earlier. And seeing a fairly large opening there, and we're retracting. And this is getting into real serious territory, and we're getting a bunch of blood out of there. That's a muscle hook loosening up some of the clot that's in there. Oh, my goodness. And then we're going to place a ring into the bag just to keep it inflated, but under positive infusion. Now the bleeding is apparently stopped. We've got an external point. And then we're going to call it a day for a while. Now we're putting in the Sione ring. We're not going to do anything with fixation because obviously the quadrant in which we would fixate it has this big giant suprachoroidal hemorrhage there. So we're just putting that in to keep the capsular bag inflated. And then 4 months later, we came back for a second stage of the procedure. I'd love to show you that whole amount, but unfortunately, while we did our secondary implant lens, eye stent ×2, custom iris placement, and capsular fixation, the tape was lost. But the last image of the case did pretty well. This is the patient at their final follow-up visit, 2025, tension 18 on one medicine. And so overall, a very happy result. The key things for the suprachoroidal hemorrhages are the patients usually say, wow, something hurts, distortion in the red reflex, shallowing of the anterior chamber, which did not happen in this case because it was a vitrectomized eye. Posterior pressure, unless the eye has been vitrectomized, iris prolapse, increased IOP, and a view of the retinal blood vessels through the pupil is definitely a bad sign. So infusions can be differentiated from hemorrhage based on color. There can be venous or arterial effusions. The pressurized anterior chamber is super important, and generous scleral windows, ideally by a retina team member if they're available. The management of pressure and pain post-op are the biggest challenges, and this is one of victory snatched from the jaws of defeat. The risk factors for suprachoroidal hemorrhage are all listed here. As it turns out, though, only the bottom three are potentially modifiable risk factors, and really can we only modify the bottom two, the systolic hypertension during surgery and intraoperative tachycardia. Anticoagulants, maybe we can modify that just a little bit. And we're going to go back over to Ike.
Well, Mike, I'm a little bit disappointed you didn't try to finish the whole case. I mean, that's not like you, but I think that was very wise.
I was using the tray on the left.
Well, and I'm impressed that you also, we're turning into a glaucoma surgeon as well, which is awesome. Okay, these are some of my old iPhones. You see, I do a lot of trauma to my iPhones, so it's always good to have new iPhones coming out every year. So this is a case of a patient who came to see me. She had fairly good vision, but very, very upset by the appearance of her eye. You can see the left and right eye. It's something she's a nurse, and she was very, very self-conscious about this. This is a history of trauma many, many years ago, and she really, wanted something to be done. She had good vision. Her lens was clear. I don't know how you feel, Michael, about these cases because, of course, we know that cataract formation is a concern, but this is her pupil here. And this is a situation where we have to think about getting that pupil centered. This requires a bit of craftsmanship. Let's see if we can try to release some of the synechiae that are present from a traumatic injury there at the limbus. We'll cut a little bit with a pair of forceps. Again, this is that pencil tip cautery, which is very handy to allow us to kind of really move that pupil up. So I start with the cautery first to bring that pupil up. It's amazing. You can bring that pupil up almost to that superior angle if I really wanted to. So you have to be careful not to do too much, but just do enough, and we can always do more here. We're stretching that iris here to get it superiorly. doing a bit of sphincterotomy as well with using a Kugeln hook to cut some of that sphincter. And then we also know we're going to have to release and making a relaxing incision here. Remember, she's phakic, by the way, so this is her natural lens, which I did warn her. She's got, certainly a fairly high risk she's going to develop a cataract, and she fully understood this. We've actually had a pretty good series of patients that are phakic now that we've done iris repairs on. One could have thought about a prosthesis here, but I really, really try my best to try to use the native iris as much as possible. And then we'll piece together the iris using microforceps, passing sutures here, tying sutures various ways, micro-tying forceps, sliding nuts into the eye, seeps or sliding knots can be used, and mechanical suturing can be done as well as intraocular tying. But basically multiple sutures passing through here and closing that defect. You can see there's a bit of a teardrop appearance, again, from another incision using the cautery. This really helps to save us to try to create a round pupil, which is what she was really after here. There are of course, some stretch holes that are present here, but she was very happy with the post-operative appearance. This is just an immediately post-operatively. She came back a few years later, though, with a cataract. So now I've got
surprising.
A cataract. we actually have a lot, but very happy. She actually told me, listen, if I can't see out of this eye, I'm still so happy with the result. And actually, I'm just going to show you here because we actually have maybe about 30 phakic iris repairs, and we follow all of them. We ask them all of them because we're really curious what happens with them. Some of them are even 8-9 years later. This is actually my first case I had to do a cataract on in one of our cases. So in this case, I'm going to put some iris hooks in, trypan blue. In fact, she has got as expected, more of an anterior subcapsular cataract with some folds there, and the cataract goes fairly well. I'm going to put a Morcher sector shield in just because she's got some transillumination defects inferiorly from her sutures tracts, and so we're going to put that inferiorly, pop an IOL in there, and then we're going to place multiple sutures, actually not too many sutures, just a couple sutures just to bring that iris together. But I think she actually looks better now after her cataract with the pupil than she did even before the cataract formation. So phakic repairs are something that we can do if we need to, and be prepared for a cataract as well if needed after the iris repair, opening the suture up a bit and then repairing again as needed. All right, Mike?
That was a beautiful case, and it's always good to get a second bite at the apple. I'm glad you got to come back and make it even better the second time. That was awesome.
The second chance always helps, man.
So should we jump into the next talks? I think we've used up most of our regular time for this.
Now it's the Mike Show. Now it's just the Mike Show. Over to Mike. Always a pleasure working with Mike. And for those of you that have not been to the cataract surgery telling like it is, Mike and I have been there from the beginning. It's going to be in Orlando, I think, right?
Orlando this year.
Orlando
yes,
next year in
last
February.
Week of January.
I've met many Dominicans there at the meeting, so please come. It'll be what, the 10th Mike and Ike show?
It'll be the 9th.
The 9th Mike and Ike show.
It would have been the 10th.
Yes. So we'll hope to see you there as well. Over to you, Mike.
All right. So the next topic that I've got to present for you guys is the pars plana vitrectomy for the anterior segment surgeon. I want to talk about a bunch of things. First, my disclosures have changed since the last case, the last presentation. So why should we as anterior segment surgeons go through the pars plana? Let me just get a quick understanding. Who here in the audience, anterior segment surgeons? Okay. Posterior segment surgeons? Okay. So feel free if anybody wants to heckle me, that's fine. I don't mind. I don't mind a little heckle. So why should we go through the pars plana? Well, there's good reasons. Visualization is better. If we're taking instrumentation, putting it through a limbal incision, it's going to distort the cornea and our view is not as good. These are two pictures of the same eye actually after a vitrectomy was performed. One is showing the same instrumentation through the limbus, the other through the pars plana, and you can see the distortion. If we're working through the pars plana, we have a pressurized globe. Limbal incisions do not seal around a vitrector, so we have less risk when we have a pressurized globe, less risk of suprachoroidal hemorrhage, less traction at the vitreous base, less issues with concerns of maintenance of the normal anatomic relationships, and vitreous is a fluid. It will follow pressure gradients, right? The lowest pressure is at the vitrectomy port, not at the limbal wound where fluid is egressing. So I always like to go through the pars plana for anterior segment approach. It's much easier to remove subincisional vitreous, and we're pulling vitreous out of the anterior chamber, which possibly has less direct and indirect traction on the vitreous base. And an anterior vitrectomy for anterior segment purposes via the pars plana is a different procedure than a 3-port pars plana vitrectomy with membrane peeling or macular hole repair. The goals are different and the approach is different. Why shouldn't we go through the limbus? Well, view. Why should we pull vitreous forward? We don't want to pull vitreous into the anterior chamber. We don't want to have limited access, and we got to worry about those pressure points. The eye wall at the pars plana is really not that magical. There's just conj, tenons, episclera, sclera, a couple layers of pigmented epithelium and non-pigmented epithelium. There are no mysterious demons in there. Many anterior segment surgeons are afraid to go through the pars plana, shouldn't. Safest place in the eye to put any instrumentation through. The schema is really very straightforward. We have a 21 gauge butterfly or other anterior infusion, and we've got our opening about 3 millimeters back for our retractor with any number of different mechanisms. It's really important for us as anterior segment folks to have an anterior to posterior gradient. For the vitreoretinal folks, when they're doing a pars plana vitrectomy, they want a trans-pars plana gradient. They want a pressurization that's coming from the center of the globe. We usually want gel to go from the front to the back, and if we have an anterior infusion, that's the gradient we present. Higher pressure in the anterior segment, lower pressure in the posterior segment. Always want to make sure that our anterior segment machines are set on cutting before aspirating and the highest cut rate possible for the machine that we have. And we want to make sure that we maintain a good globe tension. But you might say, high bottle height, what do you mean? Won't that hydrate the vitreous? Well, when it comes to hydration of the vitreous, we all have our own favorite fairy tales, and that's one of mine. The vitreous is 99% water. You can't hydrate something that's 99% water. The other 1% is important, yes, and we don't want to displace that 1%. That's the hyaluronan and the collagen fibrils, and those are attached in important ways. They're attached to the vitreous base, and vitreous is invisible. Or is it? We've got good ways to look at the vitreous, either using endoillumination for lights or looking at some of the debris that may be trapped in the vitreous. We can see the vitreous moving in this instance. We can see where the capsule's moving around it. Vitreous can also be stained. My dear partner from years ago, Scott Burke, actually first described using triamcinolone to stain the vitreous, and he described it as like throwing a sheet over a ghost. Triessence is an on-label use. There are other opportunities of different Kenalog formulations. They all work. But it's important to use this technique only in an aqueous environment. If you have an anterior chamber filled with OVD, and you squirt white Kenalog or triamcinolone crystals into it, you will create a very limited view and a snowstorm, the likes of which you don't see down here very often. Unfortunately, we see some of those snowstorms up in Cincinnati in the winter. But always only in an aqueous environment for the triamcinolone staining. And this is what it looks like. We've got some triamcinolone thrown over the superior portion of that vitreous gel, and we can see it quite nicely as it enters the vitrectomy port. Notice the anterior to posterior infusion and the very efficient removal of limited amounts of gel. We don't need to remove all the gel from the anterior approach. So what gauge should we pick? What instrumentation do we need? Smaller is better. Smaller is better. 27 is ideal. There are no anterior segment machines that have a 27 gauge cutter, unfortunately. 25 is better than 27 if you can get it. Not all machines have 25. 23 is pretty good. The 20 gauge gets to be a little bit big because the fluid moves very quickly, and that's probably more than we need for anterior segment approach, and there are no trocars available. So I bring it up just so that some of you know, because some anterior segment machines only have 20 gauge cutters with them. Do realize you can't use trocars in that setting. It's important to recognize the angle of entry. People talk a lot about how far back from the limbus should we make an incision. If I'm suturing a posterior chamber implant lens, I might make my incision along this track. But if I make it too deep, I might get the ora serrata. And if I'm going in through the pars plana to make a vitrectomy incision, I want to be perpendicular to the eye wall. 25, 23, and 27 gauge cannula and trocar systems are wonderful. Remembering that the vitreoretinal attachments are strongest at the macula, optic nerve, and vitreous base, it's nice to be further away from the vitreous base by having a cannula in place. Much safer, especially for us anterior segment folks without wide-angle viewing systems. So first we overpressurize the globe, then we displace the conjunctiva over the planned site, and we'll show that here. We're going to displace the conjunctiva, the globe is pressurized, and then this 25 gauge point just right straight through, 3 millimeters back perpendicular to the eye wall. Sometimes it gets a little hung up at the flange, and so we just give a little bit of rotation back and forth, perhaps a little counter pressure on the other side. We visualize the tip of the blade to make sure that there's nothing draped across it, which we'll see next. I've never actually seen anything on the tip of the blade. That's good news. And then once we've got our access point, we have an anterior infusion, and we place our vitrector through the cannula. It slides in comfortably. We'll pressurize only when the vitrector is in place. And you can see this implant lens has a different kind of problem. It's also got some lens iris diaphragm retropulsion, so we're just going to lift the edge of the iris so that the chamber comes back down into a more normal pressure. Bob Sioni taught me that technique. And I'm not going to show you the removal of those two implant lenses that are fused together with interlenticular opacification. That's for another time. For plugs that do not have a sleeve on them, the friction fit, or for cannulas that do not have a sleeve, a friction fit plug will keep it from leaking while we're doing other maneuvers in the anterior segment. And then we do our vitrectomy, we chomp, 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 and we move the vitrector head slowly while we're aspirating so that we don't, and cutting, so that we don't put any traction, watching for movement. If the vitrector is in view and in focus without a contact lens or wide-angle viewing system, we're not going to be able to hit the retina. So as long as we stay in focus, us anterior segment folks are going to be fine. We don't want to go beyond the vitreous, near the vitreous base, beyond the iris root. It's important to know for anterior segment surgeons how your particular machine behaves with different viscoelastics. If you are using a smaller lumen, like a 25 or 27 gauge instrumentation, and you have a dispersive OVD in the anterior segment, you will not be able to get any movement through that tubing unless there's an adequate amount of vacuum applied. So do be familiar with your vitrector device and what vacuum you need to pull the viscoelastic material through the tubing. Otherwise, the vitrectomy will be ineffective. Once we're completed, we come off of our pedal from cutting. We remove the handpiece and plug the cannula if it's there. We pressurize the globe. We pull the trocar out. And there's often a little bit of a low bleb the first 1 or 2 days. Some surgeons might choose to place a radial suture through the sclerotomy site. Typically, if I'm doing an anterior segment case where I need to do a limited pars plana approach anterior vitrectomy, those cases are usually ones where the pressure being high post-op is more common, so I don't mind a little bit of a bleb the first few days. And just removing them is really very straightforward. I just call it the grab and go. We grab it, and we pull, and we just put a little pressure over that site and allow the conjunctiva to fall back into its normal place. And that's what it looks like without the trocar in place. So just running through a typical case like this, this case has vitreous already in the anterior chamber around the edge of the lens. We're placing our 23 gauge cannula and trocar. We're going to put a plug in there first. This is not a valved incision. And we're putting in a little bit of that triamcinolone for staining, the sheet over the ghost. Now we've got a great view. We're going to go behind the lens. We want to make sure not to nibble the lens. And we're just going to let this vitreous come to us from the anterior to posterior gradient. Now notice this gel over here, which is a little bit harder to see. If we see it really well, if it's stained, if we did not see that, it might not have been as easy to detect. So we're going to sever its attachments first so that it's no longer attached to the vitreous base. And then we can come around a little bit more anteriorly to address it once those attachments are severed, so that we're putting as little traction on the vitreous base, and that's really the whole goal. And at the end of the case, we've got a sutured ring in, we've got an implant lens in the capsular bag, and I just can't help but show you an artificial iris case while I'm in there, even though it's not topic. We'll come back to that later tomorrow, I think. We then stroke the external part of the sclera to make sure that the wound is closed as tightly as possible. There are nice valved trocars, and the valves work really nice for many cases. This is a 27-gauge valve system in a combination case with my vitreoretinal colleagues. One of the things, though, that we need to think about with the valved versus the friction-fit cannulas is that with the valve, if you have a phaco machine that has a forced infusion, oftentimes the forced infusion will continue to increase the pressure in the eye until it blows through the valve. So you need to make sure to either lower your infusion pressure or you need to have a very strong valve. And the pars plana approach is less likely to damage remaining capsular support. Thank you very much. The Sione ring is a wonderful tool, works really well. It's not always easy to get a Sione ring in. And Ike invented the Ahmed segment, which is a wonderful device when you can't get a Sione ring in. But it's not always easy to get an Ahmed segment in either. It requires 120 degrees of opening in the capsule and is not always as technically straightforward, but there are a number of novel capsular anchors, which I want to show you today, which I think are kind of fun and exciting. None of the things I'm talking about are FDA approved. That's more important for me than for you. You guys can access everything. You guys are lucky. So we talked about Ike's wonderful segment, and it is really, truly a great, great device. It works very well. We can place it in, but we do need to have a pretty wide open capsular bag. Why do we need any other fixation devices? What does this not fill? What's the need? Well, let's take a look. First, we need to think about the arc and the torque that any device places on the capsular bag. So when we look at the capsular segments and arc, a segment covers about 4 clock hours of arc, or 120 degrees. So if we have a nice capsulorhexis opening and an open fresh bag, that works out pretty well. When we look at torque, there's a couple things we need to consider. Now, this is the capsular segment in the equator of a capsular bag as viewed from above. When we view it from the side, the fixation point demonstrated by this purple line is right here. The capsular bag equator is here. And when we put tension on that centrifugal force, we're going to be creating tension pulling out on this. And the axis of rotation is the equator of the capsular bag because it's tethered at the other side of the eye. Now, for those people who are physics geeks, torque is force times length times sine theta, right? And as long as the capsular tension segment is flat and you've got a big capsular leaflet keeping it flat, the moment arm of the torque is fairly low, not a big deal. But as soon as you start to get a little too much tension, if you start pulling that segment forward, the moment arm increases and the torque increases. If it's a limited amount, the torque will continue to increase with more tension and more, and eventually it will overcome the tension in the opposing zonules on the other side, and it can potentially pop out of the bag. Anybody else in the audience have this happen? It's happened to me a few times, and it's not a fun situation. So when you don't have a pristine capsular bag, there are now other options available. Susan Jacobs has this wonderful glued hook that she's created that is kind of like a miniature paper clip, slides into the eye, goes along the capsulorhexis, and then is placed in much like a glued IOL into a Sherioth pocket. And that stabilizes by the capsulorhexis margin, but also has a support that's more peripheral, so it does not create torque. Sergienko has created this M hook, which similarly has a fixation element that is peripheral to the equatorial component, and so it does not create a torque. It does have approximately 2 clock hour coverage, though. but the fixation element being outside reduces the likelihood that it will flip out of position. Dr. Malyugin has actually created this fish hook, which supports both at the equator and the capsulorhexis margin. That covers about 2 clock hours as well, so that's pretty handy. And Ehud Asiyah from Israel has developed this capsular anchor, which in its initial version is about 2.5 millimeters wide and 3 long. Here it is supporting at the capsulorhexis margin here, and the arms of the anchor actually support the equator as well. And it's only about 1.5 clock hours, so that's really kind of a nice option when you're repositioning an implant lens that has a capsular bag that's fairly tightly adherent. So in pseudophakics, the Asiyah anchor can be slipped underneath the capsulorhexis margin, again, only by opening up 1.5 clock hours. So if there's fibrosis, it's usually not a problem. You can almost always find 1.5 clock hours to open. I'm going to run this video. This is a patient that has a long history of chronic uveitis controlled with topical steroids. The patient has a zonulopathy, and the capsular bag complex is floating on the hyaloid face. So as the eye wiggles, you'll see the entire implant lens capsular bag complex move. You'll notice that there's a fairly phimotic capsulorhexis opening of maybe 3 millimeters at most. And fortunately, we don't have any vitreous prolapse into the anterior chamber yet. And this is a uveitic eye, so we'd like to do as little as we can to disturb things. So first we're going to fill the eye with OVD, making sure to maintain pressurization. And we're going to try and lift this off of the capsule off of the implant using the blunt back side of a 25 gauge needle. We're going to grasp that little margin with the vitreoretinal max grip forceps to stabilize this while we're working. And we're going to inject a little bit of OVD and try and open just enough, just that 2.5 millimeters that we need to get an anchor in. Here's what the anchor looks like when you take it out of its little container. It's pretty small. I like to use non-absorbable suture material. Prolene actually has about a 7-year half-life when it's going through the scleral wall. Gore-Tex has an indefinite half-life, so it is my preference, although it is off-label in the US. We've preloaded the CV8 Gore-Tex suture through the fixation element eyelet, and we're just going to tuck that arm of this anchor underneath the capsule. Now we'll stabilize the capsule again on the other side, and we've got to tuck the second arm underneath, and then seat it into position as best possible. You can see with this very narrow capsular opening, it's hard to get even this small device into position. We've expanded the ciliary sulcus with dispersive and cohesive combined OVD. We've made 2 openings uphill in the scleral wall at the level of the sulcus. Now, when I mean uphill, I mean that the posterior portion of the path is further back than the internal portion. So we're making that pars plana incision uphill. We're staying in front of the hyaloid face. And we're passing the Gore-Tex suture from one forceps to the others so that we can retrieve it through the scleral wall opening. This is the same technique I use for a Sioni ring, the same technique I use for a sclerally fixated lens. And then we take up the slack in the suture, and we're able to restabilize and reposition the capsular bag. On the opposing side, we're going to, again, just enlarge just enough. You can see I couldn't open it very well 180 degrees away, so we'll just go 160 degrees. As long as we've got 2 reasonably opposing sites, that'll work. We again take the arms of the anchor, we tuck them underneath the capsule. It's quite easy to see them going under this fairly fibrotic capsule. And again, with an inflated ciliary sulcus, we retrieve these sutures using a 25 gauge microforceps. One can use either a disposable vitreoretinal microforceps. You can bend them for anterior segment use. The Grishaber forceps, by way of example, you can bend up to about 90 degrees. We're using our second instrument as a pulley so that we don't drag this along the iris margin in this known uveitic eye. And even with this relatively small pupil, we're able to effectuate a stabilization of the entire capsular bag complex with the lens in situ, all without disturbing the vitreous face, without touching the iris, and with only a corneal incision and small conjunctival cut down. Gore-Tex suture is very slippery, so we need to tie it with multiple throws. I typically do a double throw initially, and then 3 or 4 additional single throws. If you do just 1 or 2 additional throws, it might not stay. It can potentially untie when you tuck it. We put the knots inside the scleral wall and put in a little bit of intraocular carbachol myostat at the end of the case to make sure that we have as low a pressure as possible in this vulnerable eye, which surely will have some retained OVD. The anchor actually has a new design. This is the computer-generated version of it. And this is what it looks like in its initial iteration. The nice thing about the new version of the anchor, which should be coming out sometime this year, is that it can actually go in through an even smaller incision. You can see that it's actually quite robust in this porcine eye. It's very sturdy in how it holds the capsule margin and the equatorial support. And if one places a suture between the 2 arm elements, it can actually even be slipped through a single paracentesis in its compressed state, making the wound incisions much smaller yet. This is Dr. Asia's video. You see he's lysing the suture there, which allows the device to expand into its normal position. And then it can be placed into the capsular bag, of course removing the suture so that it doesn't become the world's largest floater. So thanks very much. It's been a pleasure to talk about these fun devices today.
En primer lugar, quería felicitar al doctor José Asilis Mera por este extraordinario evento, que es fruto de una gran dedicación, una gran pasión y un gran sentido de compromiso con nuestra sociedad, la Sociedad Dominicana de Oftalmología. Ahora vamos a presentar la cátedra magistral, doctor Manuel Eduardo Valdés Guerrero. El doctor Valdés Guerrero es el decano de la oftalmología, me atrevo a decir, iberoamericana. El pasado mes de mayo cumplió 100 años y está lúcido, un estado envidiable. O sea que seguirá haciendo aporte a nuestra oftalmología. Fue primer presidente, fundador de nuestra sociedad, fue el fundador de la residencia de oftalmología del hospital William Morgan, después Luis Eduardo Aybar, ahora Secanot, creador del primer banco de córnea en la República Dominicana, gran oftalmólogo, gran comprometido con los clubes de leones. O sea que nuestra sociedad se honra al honrar al doctor Manuel Eduardo Valdés. Y es doblemente el honor para mí de presentar a un gran amigo, el doctor Dagoberto Almánzar Brito, quien es un excelente profesional y una mejor persona. El doctor Almánzar se formó en la Pontificia Universidad Católica Madre y Maestra en Santiago, luego se especializó en oftalmología en el Instituto de Oftalmología Conde de Valenciana, en México, Instituto Federal, donde también realizó una subespecialidad en córnea y cirugía refractiva. Por su afán de conocimiento y de aprendizaje, luego se marcha a España, donde realiza un máster en el Instituto Fernández Vega en Oviedo sobre superficie ocular y luego se convierte en uno de los muy pocos oftalmólogos dominicanos con un doctorado, realizando un doctorado en investigación en la Universidad de Oviedo, en Asturias, España. Con ustedes, el doctor Dagoberto Almánzar, con una charla sobre la miopía, su historia desde la antigüedad hasta el presente.
Muchas gracias, doctor Stern, por su presentación. También quiero agradecer la presencia de todos ustedes esta tarde. ¿Me escuchan? También quiero agradecer la presencia de todos ustedes esta tarde y también agradecer al doctor Asilis Hijo y a toda su directiva por permitirme presentar hoy ante ustedes. Es para mí un gran honor y un alto privilegio. También Quiero también agradecer esta oportunidad porque tuve el gran honor de trabajar y aprender al lado del doctor Valdés. La miopía está concitando un gran interés en todo el mundo, en todas las subespecialidades de la oftalmología. La prevalencia ha aumentado. ¿Por qué? En los Estados Unidos, hasta el 25%, según estudios publicados, de algún grado de miopía presentan la población estudiada, al igual en Europa Occidental y en España un 25.4%. El punto que nos más interesa es Asia. ¿Por qué en Asia están teniendo de un 60 a 80% de casos con algún grado de miopía? ¿Qué estará pasando? El interés de la miopía se remonta a la civilización helénica. Los griegos ya describen la miopía en tratados antiguos. No es hasta la Edad Media, en Florencia, alrededor del año 1250, cuando se comienzan a producir en serie, a fabricar lo que conocemos hoy como los anteojos y espejuelos. Pero no fueron los médicos que comenzaron todos los aportes en el área de la oftalmología. No fueron los médicos, fueron los matemáticos, los físicos, los astrónomos y los filósofos que comienzan a tratar de entender lo que es la miopía. Un ejemplo de ello es Leonardo da Vinci, uno de los más grandes humanistas, uno de los hombres más brillantes de toda la humanidad, que describe ciertos conceptos en oftalmología e idea lo que sería en un futuro un lente de contacto. En el siglo XVII, Johannes Kepler, un brillante matemático alemán, desarrolla el concepto de la ametropía en su tratado La Dioptrie en Augsburg, 1611. En el siglo XVII también el gran filósofo francés René Descartes publica en su tratado de la Dioptrie en 1637, qué pasa con la refracción de los rayos en el interior del globo ocular. Años previos a la Revolución Francesa, Abbé Desmonceau, un traité de maladies de jeux des oreilles, el tratado de las enfermedades de los ojos y de los oídos, desarrolla el concepto de lo que sería más adelante la lensectomía refractiva, para los que creían que todo estaba ya publicado. Esto se traslada al siglo XIX con el célebre oftalmólogo polaco Vincent Fukala. En el American Journal of Ophthalmology publicó su Treatment of High Degrees of Myopia by Removal of a Lens, 1890. Obviamente, los resultados anatómicos y visuales no fueron los esperados. Tuvimos que esperar hasta 1888 con el doctor alemán Adolf Fick, quien adapta por vez primera un lente de contacto. Rápidamente nos movemos al siglo XX, donde un oftalmólogo japonés, Tsutomu Sato, publica en una revista japonesa su Treatment of Conical Cornea, un tratamiento de incisiones radiales para mejorar el defecto refractivo en pacientes con queratocono, 1939. Sato, oftalmólogo japonés, amplía su muestra y publica en el American Journal of Ophthalmology en 1950 este mismo grupo de pacientes, pero en el 53, A New Surgical Approach to Myopia, ya agrupa esa serie de casos solamente para casos de pacientes miopes. La gran revolución en oftalmología se dio en 1949. Sir Harold Ridley implanta por vez primera un lente de cámara posterior en 1949. Todos hemos implantado lentes intraoculares y la visión de nuestros pacientes y de nosotros mismos algún día se debe a la invención de Ridley. Esto dio origen y formó la inquietud de otros oftalmólogos en los años 50 donde se implanta la primera lente de cámara anterior de apoyo angular en un paciente fáquico, 1952 Barron. Estos resultados no fueron muy buenos debido al contacto de esta lente con la córnea. Aquí pueden observar otros modelos de PMMA que se implantaron en ese tiempo para corregir miopía, la alta miopía. Dunham y Choice, 1952 y 1956. Estamos hablando de lentes intraoculares fáquicos de apoyo angular. En 1959, Barraquer publica una serie de 239 casos a 5 años de seguimiento con este tipo de lente. Nos parecerá un poco rudo, rústico, pero era lo que se implantaba en los años 50. En el 2015, en la revista Oftalmología Case, podemos encontrar este reporte anecdótico de un paciente con la lente de Strampelli que duró 52 años con un lente intraocular, con córnea transparente. Observen detalladamente la pupila, cómo está atrófica en la parte superior y una córnea asombrosamente transparente. En 1964, José Ignacio Barraquer, en Bogotá, Colombia, publica la queratomileusis para la corrección de la miopía, en la cual el tallado del lentículo en la cara posterior del lentículo trataba de corregir en su momento grados altos de miopía. Los conceptos originales de Sato del 39 se traspasan a los 70, donde Fyodorov en Rusia comienza sistemáticamente a operar, a desarrollar la técnica de lo que conocemos hoy como la queratotomía radial. Todo fue felicidad hasta los 90, cuando el estudio PERC demostró la falta de predictibilidad, la inestabilidad, la migración de un paciente miope hacia la hipermetropía, a un estudio a 10 años después de cirugía. ¿Cuáles son las complicaciones de la cirugía radiada? ¿Por qué fallaron estas incisiones que prometían a un bajo costo? Por la falta de predictibilidad, glare, disminución de la visión nocturna y una pérdida a la sensibilidad al contraste. Estos factores son comunes a otras técnicas quirúrgicas que veremos más adelante. En el 1994, otra inquietud, se produce la primera publicación de una ectasia post-queratotomía radiada. Las décadas de los 80 y 90 es la década también de las lentes fáquicas de apoyo angular. Sobresalen Beikoff, la lente Beikoff de Georges Beikoff, el oftalmólogo francés, la serie ZB y las nubitas. Aquí pueden ustedes observar el diseño de una lente Beikoff en la cual tenemos enclavada en el ángulo las ápticas de esta lente rígida. La lente ZB podemos observar la ovalización de la pupila y la atrofia sectorial superior del iris. Este es el diseño de otra lente de uso extendido, la nubita, y observen bien las ápticas en estos casos. La serie Z fue desarrollada por Pérez Antonja y el doctor Miguel Ángel Sato, a quien se le dedicó la charla ayer. Estos lentes fueron de uso muy extendido en Europa. Y este es un ejemplo de uno de ellos. La última generación de estas lentes, la Vivarte Eye Care, que el Manduet y a Khrushchev caché, vamos a mostrar el diseño, diseños futuristas, diseños muy bonitos, pero que no cumplieron con las expectativas generadas inicialmente. Esta es la lente Eye Care, la lente que el Manduet cobisagra, y una evolución de los diseños de estas lentes desde el 86 hasta el 2008, cuando sale al mercado la lente de Khrushchev caché. Originalmente tuvimos muchas expectativas con este lente y estuve presente en el quirófano observando al doctor Carino González aquí presente, que implantó los 3 primeros casos de esta lente. Con la llegada del Visante en el 2006 cambió mucho la perspectiva y el conocimiento que teníamos de cómo afectaban los lentes intraoculares las estructuras oftálmicas. ¿Qué pasó con los lentes de apoyo angular? Tuvimos una excesiva pérdida del endotelio, una ovalización de la pupila, isquemia iridiana, un bajo grado de inflamación y una tendencia a la rotación. Aparecieron luego los lentes de fijación al iris. El modelo Artisan, un lente de PMMA que se engrapaba al iris. Otro modelo posterior, el Artiflex, con la óptica flexible y las ápticas rígidas. Y también el lente fáquico Artisan para afaquia. ¿Qué pasó con los lentes de fijación iridiana? ¿Por qué se dejaron o por qué hubo cierta resistencia? Y en congresos como el SCARS hubo tanta resistencia a este lente, porque producían complicaciones como atrofia de iris, glare nocturno, descentración, dispersión de pigmento, uveitis y una inflamación crónica demostrada desde los años 90. Lo peor del caso, una disminución importante del endotelio, el conteo endotelial, que condujo en muchos casos a trasplante penetrante y a trasplante endotelial. La literatura es extensa cuando habla de las complicaciones de los lentes de fijación iridiana. Volviendo o retomando la lensectomía refractiva, Bersela en el 84 reporta una serie de casos en los cuales se pudo observar errores refractivos residuales. También algo muy importante en esta técnica considerar, que es algo todavía muy controversial, es un desprendimiento de retina. Hay reportes que en pacientes con más de 10 dioptrías que no han tenido ningún tipo de cirugía, el riesgo de un desprendimiento de retina al año es de 0.4 a 0.68. Pero cuando se hace una lensectomía refractiva, la incidencia de un desprendimiento de retina llega hasta un 8%. Por tanto, esta técnica se cataloga todavía como controversial. Llegamos a los 80 de nuevo. El excimer láser, taboada y troquel, que supuso otra revolución en la técnica de corrección de miopía. Esto fue continuado en el 89 por Margaret McDonald y en los 90 paralelamente Palicaris y Burato. En el 96, una gloria de la oftalmología latinoamericana, el doctor Roberto Saldívar, desarrolla la técnica de bioptics, que es el láser posimplante de un lente fáquico en pacientes con un equivalente esférico mayor de menos 18 dioptrías, y los reportes publicados hasta la fecha reportan una buena estabilidad y predictibilidad de esta técnica. Algo que conmocionó el mundo oftalmológico a finales de los 90, las ectaxias post-LASIK, progressive corneal ectasia after LASIK, algo que comenzó porque los pacientes aparecían una miopía, por qué cambiaban tanto las topografías, por qué aumentaban esos grados de astigmatismo, qué estaba pasando. Con este conocimiento de no tratar la córnea en casos de miopía alta, el tratamiento correctivo estuvo enfocado a los lentes de cámara anterior y los lentes de cámara posterior. En el 96, Fyodorov inicia con la investigación de los lentes fáquicos de apoyo del surco ciliar, de tipo mushroom. Y luego, finalmente, 3 lentes quedaron para mostrar una evolución: los PRL, EpiLens y la lente implantable de colámero ICL. Del 90 al 97, las PRL tuvieron un uso muy extendido, pero erosionaban la zónula y caían al vítreo. El EpiLens tuvo una muy poca distribución, quedando como caballo ganador el lente ICL. Estos lentes en el 93 comenzaron a implantarse por primera vez. Fue cambiando su diseño para permitir que el humor acuoso flotara y tuviera un contacto lo menor posible con la superficie anterior del cristalino. Tenemos que dar el crédito y el mérito al doctor Juan Valle y todo su equipo, que en el año 96 comenzaron, uno de los primeros países que comenzó esta lente a aprobarse, y parte del conocimiento actual se debe a su equipo. Esta lente fue cambiando toda su evolución hasta 2011. En el 94, Saldívar, esto es una foto cedida a nosotros por él, en el cual idea esta lente perforada para evitar una iridectomía. El modelo ICL V4B y V4C con perforación central. Pero esta técnica tampoco estaba libre de pecado. También teníamos ciertas complicaciones. Teníamos unas opacidades subcapsulares anteriores de tipo vacuolar, como ven ustedes en la foto del centro, de tipo puntiforme y de tipo difuso. Esto conducía a una metaplasia fibrosa de la cápsula anterior del cristalino. Esta lente también, con otros criterios, puede producir un contacto periférico que produzca una opacidad subcapsular anterior y paracentral difusa. Recordemos que solamente los diabéticos producen este tipo de opacidad. Un concepto desarrollado por George Baikoff es el Crystalline Lens Rise. Esta diapositiva nos muestra la evolución, cómo cambia a través del tiempo esta cámara anterior, cómo los parámetros que tenemos actual en un momento dado con un paciente joven pueden cambiar por los cambios que se producen en el cristalino y por consiguiente en la cámara anterior. Todas estas interrogantes, todas estas inquietudes despertaron en mí la idea de hacer un trabajo de investigación que finalmente desembocó en una tesis doctoral. La base de datos más grande de Europa en ese momento, tomé un gran número de pacientes, 1.705 ojos de la lente V4, correspondiente a 927 pacientes con una edad promedio de 31.90 años. Nuestros resultados fueron comparados con otras series publicadas solamente con el modelo de la lente V4, en el cual encontramos solamente un 5.5% de cataratas, de los cuales 22 ojos necesitaron cirugía de facoemulsificación. Parte de esta tesis está publicada en el Journal Cataract Refractive Surgery de abril del 2015. Esta tesis puede ser consultada en su totalidad con este link. En el año 2000, otra revolución, láser de femtosegundo, cirugía corneal, cirugía refractiva, ayuda a las coronarias con el microqueratomo, fue toda otra revolución. Los equipos evolucionaron rápidamente. Atrás quedó el Esculap Meditech MEL 60 para dar paso a otros tipos de láser. Los topógrafos corneales se modificaron de gran manera. Atrás quedó la nostalgia de la ISIS que algunos utilizaron. Los conocimientos de inervación corneal, de cuándo no tocar la córnea, y los conocimientos sobre la biomecánica de la córnea y su relación con las estructuras, las implicaciones en las ectasias, nos hicieron más conservadores. ¿Qué hemos aprendido desde el siglo pasado hasta la actualidad? En casi 80 años o más, hemos aprendido, tenemos un mayor conocimiento de las complicaciones. Con la aparición de comités de ética han definido los límites que debemos llevar en la investigación. Ha habido un creciente desarrollo de nuevas tecnologías que han podido conllevar a un correcto diagnóstico. Tenemos ahora mismo una gran expansión en los medios como el Internet, como el PubMed, como el Cochrane, para obtener una adecuada información. Y también poseemos de herramientas estadísticas útiles para la validación de técnicas, medicamentos y tratamientos. La verdad siempre se impone y la verdad es la hija del tiempo. Muchísimas gracias por su atención. Muchas gracias.
Directiva presente, gracias a todos por venir, gracias por estar. Y vamos a entregarle esta placa de reconocimiento al doctor Dagoberto Almánzar por su excelente ponencia. Te felicito. Muchísimas gracias. Y esta placa dice así: la Sociedad Dominicana de Oftalmología reconoce al doctor Dagoberto Almánzar Brito por haber presentado la charla magistral Dr. Manuel Eduardo Valdés Guerrero en el 51 Congreso Nacional de Oftalmología, dado el 29 de junio del 2018 en Punta Cana, República Dominicana. Gracias, Dagoberto.